This conference will now be recorded.
Okay, so this is Monday, the 3rd of May. This is the high-risk recurrent advanced prostate cancer video chat call, and we got a full house. So eyes down and looking at your cards, and we will start. And I'm going to start with Dave S. So Frank, you'll listen and you'll get an idea of what we do, and then we'll put you up next.
Okay.
So, Dave,
Yes.
it's Dave. Would you like to share with us your last name?
Star.
Star. 2 R's?
Yes.
Okay. And how old are you, Dave?
82.
82. God bless you. Where do you live?
Las Vegas.
Okay. Well, Star is a perfect name for Las Vegas. When were you first diagnosed, Dave?
Late in 2019.
2019. Goodness. And I'm just curious, how did you hear about this group?
Through my wife, Debbie Star.
Okay. Well, we'll find out sometime, but not tonight, how she heard about us. But you're very, very welcome. We're glad to have you.
Thank you.
When you were diagnosed in 2019, what was your Gleason score?
6 or 8, one of those two.
Well, there's a big difference between a 6 and an 8.
Yeah, two numbers. Yeah. I don't remember whether it was 6 or 8. That's what I'm saying.
Okay. And what was your PSA level?
At that time,
Yeah.
I think around 17, something like that.
Okay. And where did you go for treatment? Was it a urologist or?
That was a urologist.
Okay.
Who sent me to get radiation.
Okay. So hold on a minute, and we'll get back to that. Was that just a local urologist?
Yes.
Yeah. Okay. And he sent you to get radiation, which probably made a great deal of sense, given your age. Now, do you know if that radiation oncologist did a lot of prostate work, or was he more of a general radiation oncologist?
I don't know.
Okay.
I don't know.
Okay. And before you started treatment, did they do any scans?
No.
Nothing. Did they find any cancer outside your so they didn't do any scans, no bone scans, no
That came later.
Okay. So the chances are then it might have been a 6, because if it was an 8, they would have done scans right up front, because they have to do that.
No. Okay, then they did not. So
Okay,
you're probably right.
It could have been a 3+3. Do you remember anything about that first biopsy in terms of the results? Do you know how much cancer there was, or how many cores were positive?
No, I do not.
Okay. So you started with radiation, and what sort of radiation did you have?
I don't know what kind. I went 5 days a week for 9 consecutive weeks, 45 treatments.
Okay, so you had 45 treatments. Did they put any seeds into any gold markers so that they could?
No, they did not.
So they just kept you stable, and they made like a brace for you and kept you stable?
And sent me back to my urologist, yes.
Yeah.
And then he sent me out for the scan. And I learned my prostate cancer had spread to my bones.
And this was immediately after the
after the scan, yes.
No, immediately after the radiation they did this?
No. There was almost a year in between.
Okay, so that's so slow down a minute, because I'll get there. Okay.
Okay.
So what happened to your PSA after you finished the radiation?
It slowly climbed from 0.1 all the way up to about 30 something.
So in other words, once you did
it went up every time I went to the urologist.
Okay, but right after you started with a PSA of 17, and then after you had the radiation, it went down to 0.1?
Correct.
Okay, well, that's good. Were you taking any hormone therapy?
Nothing.
Nothing. So the PSA went down to 0.1, and then, which is unusual, by the way, with radiation, and then it started to climb, and it climbed up as high as 30, did you say?
Yes, that's correct.
Okay. And then they sent you out after about a year, 2020. What do you remember what the PSA was when he sent you out to get scans?
34.7, something like that.
4.7.
That's when he said, you've got to go see a medical oncologist.
And who did he send you to? I'm keeping my fingers crossed here. Who did he send you to?
Dr. Gollard.
Oh boy.
Upton Care.
He didn't send you to the right guy. You have one of the best prostate cancer medical oncologists in the country.
Vocalsang?
Yes.
I've heard the name.
Yep. That's where I was hoping he'd send you. So who was the guy he sent you to? Collard?
Gollard, G-O-L-L-A-R-D.
Okay, got it. And what did Gollard do for you? What sort of treatment did he give you?
Well, when my first appointment with him, my PSA was 55.5.
Okay. And what treatment did he prescribe?
I am getting Lupron, and I am on chemo, of which I have had 9 treatments.
Okay.
I am on holiday from chemo. The doctor offered me a chemo rest, and I'm on that now.
Okay.
Oh, I'm sorry. I got Erlita pills.
So you're getting Lupron plus Erlita. Were you a question, were you taking the Erlita at the same time as the chemo, or did you start that after the chemo?
After the chemo.
Okay. And where's your PSA right now?
My last one was 0.6.
Excellent. Have you ever done any type of testing, any type of genetic testing?
No.
Do you have any cancer in your family?
No, I do not.
Okay. No, not with brothers, sisters?
No.
Nothing, huh? Okay.
Correct.
All right. So we have a pretty good background. Let me ask you what it is, what brings you to the call, and how can we help you?
It was my wife's idea that you when she found out you existed, that I should join this.
Did you
and
agree?
You always do what your wife says, correct?
I see. All right.
Happy wifey, happy lifey. Yeah.
You're right. But between us boys, did you agree?
Yes.
Okay. Well, I'm glad that you agreed. Is there anything? I'm going to throw it open to the guys because I think they'll probably have some questions.
Okay.
And I will say, I think it's amazing that you got yourself through 9 chemos in your late 70s, early 80s, and kudos to you, because that is really, really tough and really impressive. Do you have any questions for us?
No, I'm listening to the background earlier on. I'm listening. No, I don't have any questions right now. I'm sitting here doing some more listening.
Okay. So I'm going to throw it open to the guys. I think you've got a pretty good background. Is there anybody who would like to speak?
Can I say one more thing?
Of course.
I am on holiday from chemo right now because my body turned red, like I'm burning from the inside.
Yeah.
And it's going on now, and I wear gloves to bed so I don't scratch myself to death.
Yeah. Well, Jake's going to have something to say to you about that because he had a similar response at some point. But I will also say this, that 9 times of chemo off the bat for a man in his early 80s is very heavy. I mean, what we normally see first time around with chemo is probably 6 treatments. That's the norm. My guess is that when you had that scan, do you know where the cancer was when they told you it was in the bones? Did they tell you where it was?
Not specifically, no.
Okay. My guess is it was in quite a few places. Otherwise, they probably would not have given you chemo. They would have just given you the Alida up front instead of the chemo.
I would have thought that, yeah.
Yeah, so that's the protocol. That's usually what they do. I'm going to throw it out to anybody. Is there anyone? Let's start with Jake. Jake, didn't you have issues with rash with your docetaxel?
Yes, I did. It was, it wasn't an allergic reaction or anything like that. What it was the chemo needle I was getting in my veins, and the chemo apparently didn't get into the vein and it got under my skin. So I got a red rash on my left hand. It's faded considerably over the last 6 or 8 months, but it's still there. There's a technical term for it, invasivation, I think, or something. I don't know this. I forget the spelling of it, but did they tell you it was an allergic reaction, or did the needle or did the chemo get under your skin? Did they know?
No, they didn't tell me that. And I got a port installed in my chest, making it easier for them to get the needle in.
Right. Well, that's why I have a port too, for the very same reason.
Okay.
So the rash happened before you got the port?
No, after I got the port.
Ah, okay. So.
The rash happened after you got the port. I do have a question. Did they change the dose after you got the how many treatments did you get after you got the rash, Dave?
None.
None.
The rash came after my 9 treatments, my 9 chemos.
And do you know, were you getting your chemos every 3 weeks?
2 weeks.
Okay, so they were. So I see what they did. What they did, and I should have asked you before, what they did is they gave you a slightly lower dose, and they gave it to you every 2 weeks instead of the full dose, which they usually give every 3 weeks.
Okay.
Now, sometimes they'll go even lower, like with Jake. Jake was getting his every week, but there are other guys on this call, like Ken, who get it every 3 weeks. So they can play around with the dose if they see that you have side effects. Did you have any other side effects?
No.
No.
One thing I want to mention, I'm not covered on Dr. Vogel. I'm sorry, I don't know his spell. Vogelsong? Yeah. My insurance does not cover him.
That's a great pity. Well, you know, you're probably what Medicare supplement do you have?
What other kind of supplement?
No, what Medicare? What is your Medicare supplement plan?
My medical care plan. What's
Medicare. You're on Medicare, right?
You're on Focus. You're on Medicare Focus. Medical Focus.
Is it an Advantage plan
Focus.
or is it
Focus plan?
Okay.
It's an HMO.
It's an HMO. Okay.
Yes.
So there are ways to get to Dr. Vogelsang, but you'd have to switch your Medicare supplement plan next year. But we really like him. He's such a good doc, and he understands prostate cancer really, really well. But as it stands, you're doing pretty well. So, anybody else want to say anything to Dave? Anyone else want to talk?
I have a question.
Go ahead,
This is
Tom.
Tom. I have a question. I just, as far as the chemo, is it all docetaxel, or are there other types that he could have taken?
Is it all? What was the name you said?
Docetaxel.
Yeah, what was the name of the chemo?
Docetaxel?
Yes. What type of chemo were you getting, Dave?
Hang on just a moment. I'm listening. My wife's in the background listening to me.
Why don't you bring her forward and she can talk to us? She's allowed.
They'd like to have you get on. She's running up the stairs. She doesn't get up as fast as she used to.
I bet she doesn't. But she does. She can.
She just turned around and gave me the finger. How do you like that?
I like your wife.
Yeah, I do too.
Are you there? She's on.
Yeah, she's trying. She's running. She just doesn't get up the stairs as fast as she comes down faster.
I bet, especially when you're misbehaving, right?
I wouldn't do that.
Oh,
Hello.
Okay. Hello.
Hi.
Hello,
Hi.
Mrs. Starr. How are you?
I'm fine. How are you?
I'm fine. How did you hear about us? Where did you find us?
I was searching for help, and that's how I found you.
Okay.
That's how I found you. Online, looking for help, looking for guidance,
Okay.
looking for someone to answer questions.
So a couple of things. The first is that we welcome caregivers. There's another lady on the call who we're going to talk to soon, so you're always welcome to join yourself. Secondly, we have a special group for you, for caregivers, which will meet tomorrow at the same time in the same room, just like you joined today. And that's a group just for caregivers because we want to support you.
Thank you.
Okay?
I've attended one.
Yeah. But I think you might have attended an Us 2-1. You haven't, I don't think you've attended one of ours.
Oh.
Okay, so we have one for caregivers for advanced cancer patients.
Oh.
And we have a
Okay.
lot of expertise. And if you want to join with the telephone, you join exactly the same way as you did today.
Okay. What
Okay.
time is that?
Same time as this one, 5 o'clock tomorrow night.
Okay. Thank
Okay.
you.
So make a note. And if you want to give us your email, we'll send you reminders.
Okay, I'll give you the email because I will not remember. It's coexist, COEXIST, at cox.net.
Oh, that's a great email. coexist@cox.net. We'll register you afterwards. We'll make sure you get reminders for this call and for the other call. And like I say, come on the call tomorrow night. And you know, it's a call where you can bitch and moan about your husband. Okay.
Yeah,
okay.
Okay.
Now let's ask you. Do you have any questions about his treatment?
Well, I do and I don't. I mean, I do because you know, he was on. You were talking about medicine, and that's kind of where I went on the first call. I was talking about the journey and the Lupron and COVID and the lack of availability and the supply chain and Eligard and then docetaxel coupled with
dexamethasone. No,
it's Decadron. So
Oh,
at the time that he'd get the Taxotere, 1 milligram, he'd get Decatron, also 1 milligram.
Right. That's the same as dexamethasone.
Oh, I'm sorry. Well, thank you for explaining that to me. Because anyway, that's what he was taking. I mean, that's what he was getting. And then they coupled it with Erlita.
Yeah.
And when he started the journey, it was Lupron and Casodex.
Right.
And then Lupron 30 wasn't available, and so they gave him Eligard.
Yeah. Well, not really sure why they had him on 30 anyway, because unless it's a special circumstance, most men will take a longer shot. But 30 is fine, but it's just inconvenient because you have to go back every 30 days to get another shot. But most men and most of the guys on this call who are taking an LHRH drug like Lupron are getting probably at least 90 days or 120 days or some even 180-day shots.
Oh my.
So I guess I'll ask you the question again. We're going to have to move on pretty quickly now, but is there anything that you want to ask about Dave's treatment?
Yes, I don't know what to do about his skin. I mean, I have tried everything that I can, and I spend like an hour every night. I've bought clothes because he gets cold every day at 3 o'clock, ice cold. So to soothe that, and then every night I've got a medical station set up here.
Yeah.
With primarily homeopathic type stuff and non-chemical type things to help him, which seems to soothe the pain. And it's helped in a lot of areas because he had it around his neck, and I don't know what to do. I mean, I've got this new frankincense and myrrh oil with all of, really good essential oils in it. And so I try that. I started out with coconut oil, and that stopped it, I think, from going up his face.
Fever, and by Thursday morning it had gone to about 104, and it stayed there for a while, and I couldn't stop shaking. So the hospital I went.
Thanks, Jimmy. Look, a couple of things. One is I happen to have a friend here in town who's a nurse practitioner, and she also works a lot with essential oils. I don't understand them, but I know they work. I will be happy to ask her whether she agrees with frankincense and myrrh for the rash. But more important, have you discussed and what has Dr. Gollard said about treating the rash?
He didn't. He said it was chemo. And actually, basically everything that I heard over there was Benadryl.
Okay, so let me come back to this. Here's one thing that I really would strongly recommend. You need to get a palliative care doctor on your team. Okay?
I let the palliative people go, and I brought in a new palliative group. But there's no doctor involved. It's nurse practitioner along with an RN, and I like the dietitian. I work with the dietitian a lot.
Sure. Well, the palliative group should have, first of all, you're very smart. Your husband's very lucky that you brought in a palliative doc, because most people don't understand that palliative docs are not end-of-life docs. They're there to help you with the symptoms and the diet and all the other good stuff. That nurse practitioner, if she's worth her salt, is going to have some suggestions for you for that rash. That's right in her wheelhouse.
I'm sorry to report that after the first meeting, after I actually let their palliative go, and after the first meeting, bringing in a new palliative team without a doctor, with just those three, she looked at the skin, and really, I don't think she offered anything about, treatment options. she asked what we had been doing. That was our first meeting with her. And so I'm continuing on using, not just essential oils, but I found a lot of really good products that have really helped soften the skin because it feels like leather.
Yeah. So let me stop you because I'm afraid we've got to move on.
Okay.
Let me just ask, is there anybody here who has any suggestions for the rash? Anybody on the call got any suggestions for the rash?
Hi, Carlos here. Can you hear me well?
Sure, Carlos, yeah.
Yeah, I don't know. I didn't hear whether this rash is causing him a lot of grief with itching.
Yes.
Yes.
Okay. The Benadryl will certainly help, but as you get older, it can also make you very drowsy, dry your mouth. So if you want to try it, you can. Just be aware of that. And I would basically, 25 milligrams is, if you're going to 50, pretty much that's about as high as you want to go. There is a different medication that can work that doesn't cause these other side effects. It's called Periactin. And I'll put that onto the chat line so you have a way to look at that.
They're on the phone. They're on the phone, Carlos.
How do you spell that?
I'm sorry. I'll spell that for you. Periactin. Periactin. And give that a try. It is an old school medication, but it works. When nothing else works, that one does.
He's taking an antihistamine, Claritin every day, and that was every day. That he takes that every day. But he's got chronic kidney disease as well, so I wanted to make sure.
You'll have to, yeah.
So here's what I suggest, and I'll throw in one very old remedy that I used when I was a kid because I had horrible eczema, but it did bring me relief, which is the old calamine lotion. Is calamine lotion still acceptable, Dr. Carlos?
Yeah, absolutely. You just look like a big pink popsicle, that's all.
That's right, you do. You look like exactly.
I was going to do that. I was going to do one leg, but I was afraid. I was going to do that actually tonight or tomorrow. One leg with calamine and then one with the frankincense and myrrh. But I layer it. I've been layering it with all kinds of stuff like it doesn't matter.
Well, listen, I can't give medical advice. I'm not a doc. We have a couple of doctors on this call. I'm not a doc, but I'm telling you about calamine lotion from my own experience.
Yeah, so, I remember it.
And then somebody in the chat window, which you can't see, is suggesting lavender oil. And we have another doctor on the call who's suggesting Sarna lotion, S-A-R-N-A lotion, which has menthol.
Oh,
yes. S as in sugar.
Got it.
A-R-N-A.
I got it.
I'm afraid we've got to stop at this point, but please come back because we can help you, as you can hear. And,
definitely.
We meet every week. You've seen our schedule, and you'll now start getting the reminders. And Mrs. Starr, what's your first name?
Debbie.
Debbie. Okay, Debbie. Great. And hopefully I'll hear your voice tomorrow night on the Caregivers call.
Thank you. You will. Absolutely.
Thank you. Okay.
Thank you, everyone. Bye-bye.
Pleasure. I'm going to turn this over to Len to speak with Frank. So, Frank, you got the program. Len, you're in the chair.
Yes, I'm here.
Okay, hello, Frank.
Yes.
What can I do for you?
Oh, who is this?
This is Len Sierra. Rick thought I might be able to help you.
Well, no, we need to go through. Go through an introduction with him, Len. I just want you to handle the new man introduction with him.
Oh, okay. Sorry, I misunderstood.
Remember,
All right,
I emailed you earlier on today.
Yeah, right. I just didn't understand that you wanted me to conduct the newbie interview. So Frank,
Yes.
as you may have just heard with Rick going through a questionnaire for new participants, I'd like to go through the same process with you so we can all understand why you're here, what your condition is right now, and what it is you might want from us.
Before I forget, do you have the same thing I have right now? I mean, the health issue? I mean, with the prostate?
Yes, I have prostate cancer.
Okay, but did you go, what I'm trying to say, who you want me to bring? I mean, I don't know how to tell you. I got it right in front of me. You're just a guy. I mean, you're not a doctor or anything, right? You're just a guy that's struggling with cancer. Is that what you are?
That's correct. I've been. I was diagnosed 7 years ago. I have Gleason 9, very serious, high-grade cancer. I have bone metastases. So I've got street cred for prostate cancer.
Yeah, I see. And you're on Eligard right now?
I have taken Eligard in the past. I'm not on it at the moment.
For how long did you take it? That's where I'm interested in that. I mean, that's one.
Yeah, it was over a year.
Oh, over a year ago, or you took it for a year?
I took it for over 1 year. Yeah.
Well, you're the man I want to talk to. I noticed they gave it to me like in February, the injection, Eligard. At first, I've been feeling pretty good, but I noticed for the last week, I know it's a side effect because I got that magazine. It's sort of, it says your prostate cancer and you. Yeah, okay. Yeah. Damn. Okay. Why is it? And I know it's got to be Eligard, even though I'm taking some other medication. But I wonder, since you took it, did you feel a lot of fatigue and dizziness and tiredness when you took it?
I did feel some fatigue, some dizziness occasionally. In my case, my blood pressure dropped, so that might have accounted for some of the dizziness, particularly when getting up from a lying down or seated position.
Okay.
But these are all typical symptoms of anyone who is on what we call androgen deprivation therapy. So it's drugs like Lupron, Eligard. Lupron and Eligard, by the way, are the same drug. They're both, the generic name is Luprolide.
Okay.
They're just formulated slightly differently. One gets injected into a muscle, the other subcutaneously, so under the skin. But they both have the same effect on the body. And Frank, just one other thing. Every guy reacts somewhat differently to these drugs. Some have an easier time of it. Some have a more difficult time.
Okay.
Some have more fatigue. Some have less.
Okay.
Some have more brain fog. Some have less of that. Everybody's different.
I didn't want to interrupt you.
No,
you said brain fog.
Yeah.
Is that like memory kind of problems a little bit?
It
like
could be. Yes, could be memory. You just feel like you're not thinking clearly.
Yes. Okay. Yes. Interesting. Yeah. For a moment, I thought I was going crazy, but no, it's got to be that. I mean, that's not me. Yeah. My wife knows it.
Right. How old are you, Frank?
69.
Okay. And
how old are you?
72.
Okay, you got a couple of stripes on me. Okay.
Just a few. And
yeah.
What was your Gleason score?
Okay, back in 2016, when they did the. Okay, you want me to tell you the whole story? I mean, that's what we got time.
Assuming Rick feels we have enough time, sure. Is that all
Sure.
right, Rick?
Yeah, but maybe you should take him through it so we get through it quickly.
All right.
Well,
Yes.
I'm not gonna. If it's all right with you, I'm gonna tell you. Long story short, so you can know how I feel. In 2016, I was diagnosed with prostate cancer. In 2016, okay. They started in May, I believe. I had 9 weeks of EBRT, external beam radiation therapy.
Right.
It was 13, the PSA. The Gleason score was 6. This was in 2016. When they got through with it in August, it was 0.28. That's what the oncologist told me, and I wrote it down. And that was it. She told me that I should be. Well, she didn't. I don't want to lie. I thought that was it. Because that was before I wasn't on Medicare yet. So I went out with my life, and I started to the EBRT, man. Smooth sailing. That felt real good. Felt good. I felt great. I drove myself all over from my house to downtown because my wife she's very sick too, man. Man. But that's another story. So I felt great. So to make a long story short, I've been checking it out every 6 months. The PSA. I had to change doctors and everything in 2017 because I got Medicare in 2017. But now I got in 2000. Now, and I'm telling you now, right now, what's going on. In October, I take that back. In September 2020, they gave me a PET scan. The urologist, he's got good references. I know, okay, but anyways, he told me the PET scan came that I had a mass tissue, and they came back. How you call that? That word when it comes when it comes back, what's that called? The word
recurrence.
Recurrent, yeah. And I said, dang it, boy, did I get stressed out. So I thought I was gone for good. See, obviously, I didn't read the whole 9 yards about cancer in you back in 2016. Now I'm reading it does come back. I didn't know that. See, that's why I wasn't expecting it because I got some other health issues. So I just want to know, according to him and according to the books I've been reading, I know I got to go to urologist. He knows I have cancer, but he says that according to the books I've read about cancer, I think I'm on the right track. He gave me a shot of Eligard in February. So I'm going to see him in 2 weeks, May 12th. Of course, I'm going to get my PSA. So I hope it's lowered. I'll see what's going on. And I'm going to ask him about that dizziness. Well, he's the doctor. So, I know I heard what you said, but let's see what he says.
Frank, what did the PET scan show in September 2020? Where were your lesions?
Well, let's see if I got it here. I'm trying to see if I got it exactly. But you say you don't got some. I don't want to keep nobody. I'm trying to see if I got the copy of those. Damn. I had it here. Hold on a second.
Rick, do you know?
Yes, he did an Axumin scan. It's in his lymph nodes, but he doesn't think so. And the urologist has told him that it's contained. And I know I should have. I didn't know it was going to come to this. I always had it right here in my bedroom, but I don't want to go look for it. I know this time is limited, but it's by the prostate because I asked him. I called him on the phone and he left a voicemail. I said, "Don't you think I'm supposed to be seeing an oncologist?" And he told me that you're welcome to a second opinion, but he says that he didn't refer me to an oncologist because he don't think it's metastasis. I call metastatic when it goes to the yeah. He says he don't think right now it's not metastatic. That's why he didn't refer me to an oncologist.
Okay. Yeah.
So I just want to make. Go ahead. I'm sorry.
Yeah, the terminology is used a little differently by different doctors, so that some consider a lymph node lesion to be a metastasis, others consider only a visceral organ or bone metastasis to be a true metastasis, or if it's a local pelvic lymph node, they'll consider it locally advanced rather than metastatic. But if it's a distant lymph node, like maybe in your shoulder, then that's considered metastatic, just like bone. So anyway, the point is, after your radiation brought it down to 0.28, then I guess it started rising again, and that's why they did the scan. Is that right?
PET scan, yes, in September. I mean, I'm sorry. No, I didn't. They didn't do it till. I went to hell. They didn't want to cover it. In January they did it. Since September, if you only know how much stress I had, because I knew that cancer was going to come back. But I'm calming down. I'm hanging it up. I think I'll be all right. I gotta have faith. I'll be all right. I'll read the good book too.
So let me just make clear: are you being treated now by a urologist or an oncologist?
Urologist.
Okay. I may not be the first one to have told you this, but you should be seeing an oncologist, a medical oncologist. And not only that, but someone who specializes in genitourinary oncology. So that's someone who specializes in prostate cancer in your case, because the field is changing so rapidly. It's very difficult for anyone who is outside of that specialty to be fully aware of all the treatment possibilities for you.
Yeah.
Now, when it comes to suggesting which medical oncologist, I'll have to leave that to Rick. He knows, who are the best ones in your area. I'm not even sure where you live.
Illinois.
Illinois. Okay, yeah, Rick would know.
Okay.
Who to send you to.
Yeah, but that's what I was scared of. He scared me last time I talked to him. I don't want to see more doctors. See, I got no support. My daughter's got a problem. My son, everybody's sick here. See, and I know now I got to go look for college. That's a lot of stress on me, I mean, 2 weeks I'm going to see him. I could ask him about what the PSA is and see what, I mean, then we'll take it. Then I could tell him I want to see an oncologist. I don't think he's going to deny me.
Yeah, I mean, it's your health, Frank. Don't.
Right. I'm going to tell him that I want to see an oncologist. I mean, or what do you think?
Yeah.
When I see him, 2 weeks.
Good.
Okay. Again. Yeah.
So, Frank, what kind of insurance do you have?
Medicare, Humana. I'm on Medicare, but I also got Humana. Medicare Advantage, HMO.
So it's a Medicare Advantage HMO. So as we heard from the last person, that may not be the best advantage when you need Medicare at your stage.
So what are you trying to say?
Well, the best, some Medicare Advantage plans, and we don't know about yours, limit access to certain specialists. So that potentially could be an issue, but I think you need to find out who you can go see.
I see. Yeah. So how do I do that?
I think you'd have to look up on your plan who are the GU medical oncologists under that particular plan.
Yeah, that's why they want to see now. You know how they want that cancer to come back and stress me out.
Who wants it? None of us want it to come
back. But I thought it was over and done with the 9 weeks of radiation. I thought that was it. See, I got other issues, man. I had open heart surgery in 2017. Know that? I've been through hell, man. I mean, I feel okay. Don't get me wrong. My heart, I'm feeling good. Well, I recuperated in 1 week because I didn't have no heart attack or nothing. The good Lord was watching out for me. My timing was right. They say most of the people are 2 weeks. I was only there 1 week. I felt great. I don't have no chest pain, no nothing. But now this cancer's coming back. Yeah. See, now I don't want to get stressed out. But now you tell me I go see an oncologist. See, I get kind of nervous. I don't know. So no, but yeah, I heard what you're saying. Yeah, I called to Humana one of these days when I feel relaxed. But I'm still gonna see the urologist in 2 weeks. Might as well. No, tell him. I'm gonna tell him that I want to see an oncologist. Maybe he could refer me to one. He's a good doctor. He doesn't sound like a ignorant man. You know where I'm coming from. I'll tell him that I want to see. I'll tell him with all due respect. With all due respect, I'll tell him that I want to see an oncologist.
Hey,
take it from there.
Yeah. I mean, he did say to you, if you said this correctly, that you're welcome to go get a second opinion.
Yes.
And I think, and I'll tell you, when I got diagnosed, I'm being treated by a first-rate team, but I went and got a second opinion.
Right. Well, I am. No, I am. No, don't think.
And when I asked my team about the second opinion, they said, "Please do. You know, the more knowledge we apply, the better off you're going to be."
Okay. No, I am.
And I think it will calm. And I think more knowledge will help you deal with the anxiety in future about how do we go about dealing with this.
Right. I wish I could find a paper to show you. I mean, I had it in front of me because I know you want to know about the mass, about both sides. But,
well, I think we've heard enough, Frank, to know that you belong in the care of a GU medical oncologist, genitourinary specialist.
You won't happen to. Oh, but sorry, I got to find out who covers Humana. Damn, it's gonna complicate. I know it. See, I lately, I don't know, ever since I was diagnosed with that, I feel a lot of stress. Like, you know, that's why I was okay with the urologist. He is good. He was highly recommended. Now, don't get me wrong. He's got a good reference, but you said yeah, I know.
Hey, Frank, this is Bruce. This is Bruce. Hey, look, you know, I looked into your doctor, and absolutely, he's got great credentials. Rick said the same thing. He looked into him. The guy is no slouch. What I would do when you go there in a couple weeks, you know, ask him if he could recommend an oncologist that would take your plan. I'm sure he knows what kind of plan you have, and ask him a recommendation for an oncologist. Possibly, I see some people shaking their heads. No.
But no, what do you mean? What do you mean? No, they're not gonna. He's not gonna tell me yes. I mean, he's not gonna recommend me.
Yeah, he may not, because he wants to give you that Lupron shot, that Eligard shot, because he makes money off of it, and the urologists don't want to give you up. You know, it's like me saying to you, you go to the dentist, right? And you've got and you need a root canal, and your dentist thinks he can do it, but he's not a specialist in root canals. But he says, I can take care of it, and he does, and he may be good, he may not be good, but you're better off going to see somebody who's the specialist. That's what we're trying to tell you. And this guy is not the right doctor for you at this point. Your disease has come back, and urologists like to treat people like you, but they're not equipped to do it. They don't have the knowledge.
Can I ask you a question? Can I ask you a question?
Can I pipe in it as a doctor here? Is that, I think your name is Frank, sir?
Yes.
Okay, so Frank, this is what I would suggest you do. What hospital is your urologist at?
At South Suburban Hospital.
Okay, South Suburban Hospital, that's part of the advocate system. So what you should do is call up South Suburban Hospital, I know it, go to the physician locator on the website, tell them.
No, I'm not into computers. I'm not into that. I don't
No. You can phone them. get the phone, and I said, give me the operator for Find a Physician Services. Recite the insurance that you have, and then they will go through a checklist of the oncologist who accept your insurance. Advocates South Suburban is a decent hospital, but it's affiliated with that huge Advocate Aurora system, like Advocate Christ. So you might need to travel to Christ Hospital, which is a top-notch hospital.
Right, that's where they did the surgery. Yeah, I know, right. I know where that is. Christ Hospital, I know where that is.
That's where you could probably feed into with your present insurance.
Okay, I'll go. Right, I know where that is. Yeah.
Yeah, so use a phone, and what I would do is actually preferentially call Christ Hospital and say, I need an oncologist who has an interest in prostate cancer, and this is my insurance. All these gentlemen know that the bills are staggering. So you need to stay within your insurance plan. So call Christ Hospital tomorrow and ask for the operator that deals with Find Your Insurance. And question number 1, 2, or 3 is, what is your insurance? And then they'll find the doctor that matches up.
Okay. All right. All right.
Okay.
That's all I can do.
We're gonna have to move along.
Okay.
And Bruce Bocian, Bruce will stay in touch with you, and Bruce will come back to us if we need any more guidance. But the most important thing is you don't want any oncologist. You want an oncologist who specializes in prostate cancer. It's really important. Okay.
Right. Before I let you go, can I ask you a question?
If it's quick.
Do you think they're gonna? I'm not crazy about it. I'm hanging in there. I hope they don't give me chemo. You know, that's all. You didn't give me.
But you can talk to your doc. You can see what the doc says.
Yeah, you're not a doctor. I forgot. I'm sorry.
No, you can come back on this call and you can talk to us again.
Okay. Thanks a lot, Rick.
Hey, Frank. One quick statement before you go. My wife is a nurse in case management. She deals with insurance like that. If you need some help calling that hospital and finding out which oncologist that would take your plan, let me know. She can maybe even make the call for you and help you out. All right?
That'd be a blessing, bro, because I got your number. So.
Hey, you have a good night.
Okay.
Thank you. Now, I was hoping we could move straight to Eileen, but I just saw that she hung up. Are you still with us, Eileen? Okay. Well, if she comes back, we'll latch on to her quickly. She's here. I wanted to tie her into you, Bob McHugh, because her husband is suffering with pretty serious radiation cystitis right now. So let's see if she comes back on. All right, I'm going to go down quickly, and I'm going to see who needs time today. There's a lot of you, so we'll try and if it can wait.
Rick, is John Haley new?
No.
Okay. Thanks. I don't have any needs tonight. Thank you.
Okay. So let's start. Jake, anything for you, sir?
Thank you, Rick.
Okay. Bruce Bocian, anything for you?
No, I'm through for the night.
Bruce, I just got to tell you, thank you so much for bailing us out over the past couple of days with this, gentlemen. Really, really appreciate it. Joe Gallo, anything for you?
Just 2 seconds. My bone scan and CT scan came back clear.
Okay.
Oh, great.
Okay. Alan Moskowitz, anything for you?
No, thank you. Not tonight.
Okay. Jeff Marchi, anything for you? Jeff Marchi, going once, going twice. Gary, anything for you?
Yes, please.
Okay, let me just check. Eileen, did you come back on? I saw you leave. Have you come back on? No. Okay. Jim Marshall, anything for you?
Negative.
Pat, anything for you?
A quick update.
Okay. Peter Monaco. Peter Monaco, anything for you? Okay. Herb, anything for you?
Nope, I'm fine, thanks.
Jim Barnes, anything for you?
I do not.
No? Is that a no? Was that a no, Jim?
That's correct.
Thanks. And just a quick request, everybody, if you could please mute if you're not talking so we don't get the background. Dennis Correa, anything for you tonight?
No thanks, Rick.
Okay. Les, anything for you tonight?
No thanks.
John Ivory.
No thanks, Rick, thanks.
Okay. Carl, anything for you tonight?
2 minutes, yes.
Len, anything for you?
Niente nulla.
Okay. Eric, anything you'd like to talk about tonight?
Yeah, just, a couple seconds. We'll be low.
Don't estimate your time. Just tell me a yes or a no. Because you're never right when you estimate anyway. So, Jerry Palfrey, anything for you?
No, not tonight. Thank you.
Okay, Sylvester, anything for you?
No, thank you.
Okay. I came to Eileen again. Just make sure Eileen isn't with us. Okay. John Haley, anything for you?
Yes, please.
Okay. Bob McHugh, I know why you were here. Sorry. I'll connect you, Bob, with Eileen offline, okay?
Whatever I can do, Rick, is great.
Thanks a million. I'll make the connection later on tonight. Okay. Let's see. Don, are you still with us, Commander?
I am, but I don't have anything I need to talk about. Thanks for asking.
I'm so glad you got home safely.
Sherry says hi, by the way.
And the same back. Jim Schrate, anything for you tonight? Okay. Carlos,
No,
anything
Rick.
for you?
Sorry, I was muted. No, I don't have anything tonight. Thanks.
Okay. Dr. Carlos, anything for you?
No, thank you.
Okay. Dennis McGuire, anything for you?
Nothing new. Thanks, Rick.
Nothing new. John A., anything for you?
Yes, please.
Okay. Al Latimer, anything for you?
Not tonight.
Larry Fish.
No thanks, Rick.
Thank you. Tom Swartzel, anything for you tonight?
Yes.
Okay. I now see Peter Monaco there. Anything for you tonight, Peter?
Yeah, I have a quick update, Rick.
Okay. I just got, oh, here you are. Got you. Okay. David Muslin. Hello. Anything for you? Yes. That looks like a yes. It's a yes. Okay. Ravi, anything for you, sir?
Yes, I have a very quick question, but if you're short on time, you can skip me. It's not important.
Thank you. Kang, anything for you?
Oh, thanks. I'm okay. Maybe next time.
Thank you. Dennis, sorry, Ken Anderson, anything for you?
Nope.
Thank you. Russell, anything for you? Russell? Going once, going twice, Russell. Okay. Frank Fabish, anything for you?
No, nothing tonight. Thanks.
Okay, and Jimmy, you better give us an update if we can get to you. We want to know how you
It can wait. I'll leave it up to you.
Okay. All right, let's start with Joe Gallo. We gave us an update that everything was clear. So let's go down to Gary. Gary, what's on your mind tonight?
Thank you, Rick. Can you hear me okay?
Not really. We can't hear you that well at all. You're echoing. Are you on the phone and on the computer?
No, I'm not on the phone.
Okay.
But it's echoing for me too.
Yeah, I don't know where. There you are. I see you now, but I don't know why, but you are reverberating. Try again. Because I see another Gary, I see another G here, and I'm wondering where it's coming from. We're definitely getting reverberation from you, Gary. It's just echoing and echoing. Let me.
Okay, if you need to skip me, go ahead, Rick. We can try again later.
Yeah, we'll try. What about my tech wizards? Any suggestions here for Gary?
Have him log out and just log back in and make sure he's not connected multiple times.
Yeah. Can you
log turn off your camera.
How about now?
Well, I think we can go with you. So why don't you tell us what's going on? You're not reverberating, which is good. Now we've lost you altogether. Now you're muted, Gary.
I started 8 weeks of radiation today.
Okay.
They're doing the radiation because they believe that the metastasis is confined to the regional lymph nodes. But they're basing that on negative bone scans and an Axumin PET scan that were taken 6 and 9 months ago. So my question is, how can they be doing a radiation program in the supposition that the metastasis is still locally confined when those tests are so old at this point?
Well, what exactly are they radiating? Do you know?
The pelvic girdle and then the prostate bed.
Okay. So if they're radiating the pelvic girdle and the prostate bed, that is a blanket type of radiation. So they're covering everything. So they're not aiming the radiation at anything in particular. So what they're saying is, we know that there's something going on there, but we're going to go across everything. And,
right.
So
but they're only doing it because because they found no metastasis in the bones or in one of the distant lymph nodes or an organ.
Okay.
But how do they know that metastasis has not occurred in the last few months?
Well, what you're saying that you've had no scans at all since when was the last time you got a scan?
I've had some CT scans of the pelvis, but I had a systemic, the only two systemic scans were a bone scan in August and a PET scan in October. Nothing since.
Okay, and what's your PSA history been since the beginning of the year?
After I got on, after the prostatectomy, it was still around 3.5, 4. After Lupron and Zytiga, it's undetectable.
So after the prostatectomy, your PSA, you say, was 3.5 to 4. That was immediately afterwards?
Yes.
Okay. And was that when they did the scans?
No, the scans had been done, well, it was about the time as the PET scan. The surgery was in September, the PET scan was October.
Okay, so they did a PET scan after the surgery, at which point your PSA was 3.5 to 4, and they didn't see anything. Is that right?
Correct.
Okay. So I guess what they're saying is, if they didn't see anything then, and you've been on Lupron and abiraterone since that time, the chances are they're not going to see anything now. And I mean, I understand that. If you wanted to be 100% certain, you could tell them you want to scan again right now. When did they do the Axumin scan? Was that the one that they did in October?
Yes.
Okay. So to be certain, you could do it again. But what they're saying is Axumin showed nothing when you were at 3.5 to 4. It's not going to show anything now because your PSA is depressed. And so we just think that wherever you've got your recurrence, it's probably in the pelvic girdle somewhere and in the lymph nodes and in the prostate bed. And that's why we're doing this type of radiation. Anybody else want to comment on this? Anyone else chomping at the bit to get a word in here?
I was wondering why they're radiating him if his current PSA is non-detectable.
I mean, that's sort of a good question too. I think go ahead, Gary.
I was going to say, I think the answer is they know there's cancer left behind.
Right.
They know there is some cancer somewhere. They just can't see it.
Right. It's micrometastasized, so they're going to blanket the girdle and the bed, and they're going to try and nail it that way because the chances that it's beyond that, given the Axumin last October, are probably low. And the fact that you've been on Lupron and abiraterone, I mean, and you're still castrate sensitive.
So that seems reasonable to you?
I understand it. Let me ask the guys, does that seem reasonable to you? What does the group say in this sort of a situation?
This is Carlos. You know, I'm a scientist when it comes down to it. I would myself probably stop the hormones, let the PSA start to creep up, and when it hits 0.05, get a PSMA study and see where it is, and then you go back onto your hormones because they can aim for what was where it showed. My 2 cents.
I suggested that, Carlos, to my oncologist, and he said, I think that's a bad idea. You wanted to be aggressive. I think this is the aggressive way to go.
You see, the thing is, Carlos, that if they saw, the likelihood is, if he let it rise, that it's still going to be in the prostate bed and in the pelvic girdle, and probably not in the bone. And so they're saying, well, we know it's there. We may as well radiate it now rather than radiate it later. We could let it rise and see, but we're just going to find that it's where it is right now. So why let it grow? Why not nail it, go in, with guns blasting? Has anybody else on the call been in this situation?
I think I have a little bit.
Speak up, Jimmy.
I'm sorry. I think I have a little bit.
Yeah, no, sorry. I meant to say, yeah, you got the platform. When I said speak up, I meant the floor is yours.
Oh, I'm sorry. Yeah. No, I think just a little bit because, I had undetectable PSA after prostatectomy, but because the pathology report showed a lymph node and seminal vesicle invasion, they didn't hesitate to give me very aggressive treatment. Of course, this was 2 years ago in the dark ages when getting a PSMA PET, especially when you had undetectable PSA, not only wouldn't show anything, but well, it's still true. You have to spend a lot of money, and but the idea is it's only been around a little while that they wouldn't just leave you alone. And I can understand what Carlos is saying. That's a tough decision, but I said, well, just because it might, you might be treating nothing. I'm fairly young and I'm in as favorable position as I can be for having unfavorable pathology. So I went ahead and did that. So I may never know if it did me any good.
It's a real tough one, Gary. I understand why they're doing it. There are alternatives like letting your PSA come back and getting that PSMA scan or another Axumin scan. But for me, it sounds like, and again, we can't give you medical advice, but the way it sounds to me is this is what they're going to do anyway.
Right.
Do it now rather than doing it later.
Right. Okay. Thank you.
Okay. Anyone else want to chime in on this before we leave it? Okay.
This is Al Latimer.
Yes,
so you have an undetectable PSA right now. You don't know how long it's going to be undetectable just with what you're doing now. I mean, in my case, my PSA went undetectable after, I had lymph node involvement, and I started the Lupron, and my PSA went undetectable. It stayed that way for 20 years. So why go through something aggressive now unless you can see for sure where it is and what it's doing? There's side effects to all these things. That's my 2 cents.
No, it's a very valid point. You can do the radiation now, which is the aggressive route, or you can say, I'll just leave it and let's see what happens if I become castrate resistant.
Just one more quick comment. Ultimately, the big question is, which way will you sleep better at night?
Yes.
That is the best decision for you.
Yeah.
Okay.
Only you can decide that.
Right.
But if you decide, I was just going to say, if you decide not to do it right now, I don't think anybody's going to say it was a bad decision. If you decide to do it, I don't think anyone's going to say it was a bad decision. Okay.
I appreciate it. Thank you all for weighing in. Thanks, Rick.
Okay. Oh, before I forget, well, so most of you are here. Please fill out the survey we sent to you on last Thursday. If anybody on this call hasn't filled out the survey, then they're persona non grata. Now, we don't know because they're all anonymous, so I can't point any fingers, but that's how we feel about people who haven't filled out our survey. So you got the survey, you got the link, it was in there. We really want everybody to fill out the survey. It's important. It's really, really important. It is the way that you are going to make the medical oncologists and the urologists hear what you're thinking and what you want. Because we're going to take that information, and Dr. Herb, God bless him, is going to turn it into, he's going to analyze it. We're all going to, and he's going to turn it into a poster, and we're going to be shouting at some of these folks through the poster. So that's why we ask you to do that. All right, that was my push for the, and we'll keep pushing for that for probably another couple of weeks, and then we've got to get on. We've got to get into the. Go ahead, Herb. What did you want to say?
Please help us get this data. It would be really good. I mean, the whole idea is to show the clinical community that this is a valuable resource to the point where they will tell their patients, join this group, rather than having to sort of randomly find us.
Yeah, thank you. Thank you. It really is important. Okay. Jeff Marchi, you came back. Did you? Thank you,
Oh, I've been here. I just disconnected for about 30 seconds. I've been here the whole time. I didn't hear you call me earlier, but I have nothing today, so I didn't say anything.
Okay, yeah, we gave you a going once, going twice, Mr. Marchi, so that's okay. But
I had to run in the other room for a moment. It was just then.
Must have been. That's how it always is. Pat Martin, you're back and you're up next.
They unmute. Just real quick. Last Friday, I went up to my oncologist in Seattle Cancer Care Alliance, and my PSA went down to 0.17 after I started Alligard 2 months ago, and Abby 1 month ago. But the good news is that the DNA testing on the, I'll just read it. Somatic testing on prostate tissues revealed MSI high with mutational load of 14 mutations per megabase, okay. And then they give some other things. So I would be eligible after I go castrate resistant. I would be eligible for Keytruda actually. And so I think that was good news to me.
That it's not just good news, it's great news, because what we see is that men who you have a high tumor burden and your MSI high, and we know that those men do tend to respond very well to Keytruda. Can I let me throw that one back at Len and Herb, because they're the experts in this field, and of course, if you watched Larry Fong, you would have picked that up from the Larry Fong. Would you like to comment on that, either Len or Herb or both of you?
Well, I mean, I'd say it's a bit of a double-edged sword, isn't it? I mean, it's bad that that you have MSI high, but it's good because there is a treatment for that, Keytruda, namely. I don't know. It's kind of like BRCA2, like if you're positive for BRCA2, normally you say, oh, that's not good, but there is a precision medicine therapy for that, the olaparib or other PARP inhibitors. So it's a question of how much mileage can you get out of Keytruda when the time comes. Will it last for a year, 2 years, 5 years? I think it's too early for us to know because these therapies are fairly new.
Yeah, from what I've read about it, it's kind of a crapshoot how long it's going to last. And by the time I get there, I'll be castrate resistant. And reading through some of the side effects, I don't know that it's much better than some of the docetaxels and some of the chemotherapies.
You know, that's such a good point, Pat. And I noticed that Cancer Care has got a webinar coming up pretty soon on the side effects from immunotherapy. So you might want to keep your eye open for that. We'll be posting it to our blog. I can't tell you right now when it is. But I mean, we've known people that have had no problem. We've known people that have had significant problems from nivolumab and pembrolizumab. So it's definitely an issue, yeah. But it's kind of nice to have it in your pocket, and just like Glenn says, it is a double-edged sword. And you know, we've had people who have found themselves to have a BRCA mutation and said, "Oh, great, now I can take a PARP inhibitor." But I mean, do you really want a BRCA mutation? I think Carl would probably say, "No, you don't." But
Yeah.
we're coming to him in a minute, so he can tell us. He can tell us whether he thinks you do or you don't. But yes, it's tricky. Anybody else wanted to comment on this MSI-H diagnosis?
This is Carlos again. I do have a suggestion for something to keep in the back of your mind. There's a gal by the name of Joan Whitehouse, who is out of UCLA doing a study that is still in gathering data. And basically what they do is get a swab and test it to see how you will react to the Keytruda, whether you are likely to have a lot of side effects from it or not.
Yes.
And that will somehow, hopefully that will give you some guidance as to whether or not, if you're at risk to have a lot of side effects, that they can treat them early.
Yeah.
So that, just keep that in your mind. Dr. Scholes is normally connected with her. You would have to get a referral, but I'm giving you the name directly if you want to look her up and find out how your doctor may get you referred for that particular swab.
Okay. I know Seattle Cancer Care Alliance, Fred Hutch, University of Washington Med Center are very active in the genetic and DNA immunology on a lot of different fronts. So I can tap into some of them, I think, too.
Yeah, I mean, I would raise that question with your med-onc with Schweitzer. I would raise that question with Schweitzer and say, you know, what about the test? Because we know Scholes does that test. What do you think of that test for testing whether you're going to have side effects? But I don't know. I'd do it right now. And by the way, Pat, Schweitzer is going to be talking, believe it or not, on, I think it's June the 6th. He's going to be talking to our active surveillance guys because he's doing a study using a leader, apalutamide, on men with active surveillance. And so he'll be addressing them. So it's open to everybody. We'll publicize it. But July the 6th, Pat's doctor, Michael Schweitzer, who's a GU med-onc, will be talking to the active surveillance guys. And I'm negotiating with Howard and others. Joe, there's our man. Joe, do you think we can address Dr. Schweitzer with some more advanced questions at the time?
Sure. We're always open.
Okay. Now you got it from the horse's mouth because it's Joe's webinar, it's seminar, it's not mine. So any of you guys who want to talk to Michael Schweitzer on that day, join that call. Okay, we're going to keep moving. Tina Monaco.
Hello.
Hello.
Yeah, I have a quick update. So if you recall last week, I was talking about that I had a little spike in my PSA.
Yep.
And the feedback was that I should be looking at an Axumin scan or a PSMA scan. So I have a call set up with Dr. Shao for Wednesday. She's my current oncologist with Sloan, to discuss her recommendations for next steps. In the meantime, I did have a consultation by video chat with this fella, Dr. Patel, who is an associate of Dr. O at Mount Sinai. I had seen him back in January, just was kind of hedging for when this day would come when I would have my recurrence. So I asked him what would his next steps be if he were treating me today. And he was, without a doubt, at the very minimum, an Axumin scan. No question about it. He said their protocol is if you have a PSA greater than 1, and if your CAT scans and bone scans are clear, as mine were, the next step is logically to go to an Axumin scan and go for local treatment if local treatment is appropriate. Otherwise, it's systemic treatment as well. So when I meet with Dr. Shao on Wednesday, I'm going to have some decisions to make because I'm going to want to know what her recommendation is going forward. And if she just says, oh, we're going to put you back on Lupron and not order one of these deeper scans, I mean, it's funny, when I talked to Dr. Patel, I told him about this group and that these are the recommendations coming from, the consensus coming from my colleagues in this group. And he was like, I absolutely agree with them. So that is absolutely the right thing to do in your shoes. So that's my update. I have a decision to make. You know, I don't necessarily want to leave Dr. Shao, but if she doesn't come right at me and say, okay, next step is we're going to have you have an Axumin scan, I really have a dilemma on my hands, I feel. So or at least I have to make a decision.
Let me just say this. I'm delighted that we got endorsed by Dr. Patel because we cannot afford to lose you, Peter, for all the fabulous volunteer work you're doing for us. So
that's, you know, I did respond to the survey and put very high value on the recordings, just so you know.
But thank God we said the right thing last week. And I think you know what we think. We've said it enough times here, and I'm very glad that you are at that point where, if necessary, you're ready to jump ship. And there's nothing else we can say. You're doing the right move, and I think the one thing the group should pat itself on the back for is that we're making you your own best advocate.
Right, right. Yeah, and Dr. Patel is an associate of Dr. O.
Yeah.
He interned under him. He said he confers with him all the time about his cases, and that if I ever wanted to speak to Dr. O, I can. So, you know, I feel like, yeah, these guys know what they're doing. And, you know, I was, you know, kind of like, you know, there was absolutely no hesitation, Rick, when I said, what do you think about this, getting an Axumin scan? He said, there's no reason not to.
Yeah.
He said, your bone scans and CAT scans are clear. That's good, but it must be somewhere. And maybe if we could find it, if we could see it, possibly we could zap it. He used that expression.
Well, let's not get ahead of ourselves. Let's do the Axumin scan, and then we'll talk with you about what to do when we know those results.
Okay, so that's my update.
Thank you. Any questions for Peter from anybody in the group? Comments, questions, anything? Len, anything you want to say since this is your institution?
Yeah, I just wanted to double check with Peter. I assume you're going to Madison Avenue, Mount Sinai location when you see Dr. Patel?
Yes, that Ruttenberg Center on
Yeah.
Madison Avenue? Yes, that's where I'm
Yeah.
going. Hmm.
Okay, yeah, good. Well, so that's great news. I mean, he consults with Dr. O. Dr. O, any of Bob McHugh and myself, and might be a few others who see Dr. O, we all think he's a great guy and smart. And so I think you're in good hands there. I would definitely get that. I had my Axumin scan done at Mount Sinai. It was from the day Dr. O said, okay, let's get you an Axumin scan. I think it was done within a week.
Oh, great, great. Yeah.
Okay, we got to move along. Jake reminds me, and I apologize, I should have done this right at the beginning, that we learned yesterday that Scott Hogan passed away yesterday. You may remember Scott spoke to us from his bed when his spine collapsed sometime in early April. None of us here at AnCan, the moderators, can really fathom what went on, because we don't see somebody declining so quickly. And I mean, I've seen people die in 11 months from the time they were diagnosed, but even that they were really unwell for the last 2 months. And Scott, even though his spine had collapsed, which meant, yes, his cancer was on the rise, I would have guessed he was treatable, but I would have been very wrong. At the same time, he never did do chemo. He never wanted to do chemo. He never did chemo. And by the time chemo came up, the doctor said he wasn't strong enough. And the group told him when he first came to us, which was about, I can't even remember when it was, I can tell you. But we tried to encourage him to consider chemotherapy. He didn't want to do it. For the longest time, we couldn't even get him over to a GU med-onc. And then eventually we did. But it's very sad, and I feel like we should be reporting it to you, since some of you will remember Scott over the last couple of years. So he first came to our group. I think it was over a year ago. I think it was probably the end of the beginning of 2020. He went to us too, and Terry Lukowski called me and said, could I help this guy, because he was in a bit of a mess. So that's, I'm sorry, I wish I had better news, but I don't. Jake, did you want to say anything?
You covered it quite well, Rick. Thank you.
Anyone else who remembers Scott want to say anything? I will say this. Most of you know I live in deep southern Arizona, about 45 miles south of Tucson, and Scott lived in Phoenix, and he was always very grateful for the support that he got from us, and I must add, the support that he got from the Reluctant Brotherhood and John Teisberg. He always said, I want to come down, I want to buy you lunch. I'm so grateful for what you've done. I mean, he made some donations to us. He didn't have a lot of money, but he did make some donations to us, but he always wanted to come down. So when I wrote to his wife, Pam, today, and if any of you want his email address for that, I can pass it to you. I said to her that you just let me know when that memorial is, because he wanted so much to come down that I will definitely drive up to Phoenix. to be at that memorial. It may not be until the fall, but we will represent ourselves at his memorial, come hell or high water. Okay, let me get back to my list here. Carl.
Boy, I hate to follow that announcement.
Well, do you want to wait?
Well, no, it'll be relatively quick.
Okay.
I am going to see Dr. Tagawa tomorrow. I am about to complete my 8 weeks on the ARV 110 trial. I'm going to be having some scans and blood work, and I guess a determination is going to be made whether it's helping me or not. And if it is, we continue on the drug, and if it's not, then we have to go on to another therapy.
Okay. So you've had no scans in the interim, from what I remember.
Correct.
Okay. Well, I guess next week's the time when you really need to report to us.
Right.
Okay,
That's why I said it was going to be quick.
Okay. Well, Peter may not be able to take it because he's traveling that day. But if Peter doesn't take it, then Len will take it. Sorry, guys. I've been looking at you. I just realized I never moved I've got too many screens here, and forgive me for looking over your heads the whole time. Okay. Well, let's see what comes out of that. And by the way, I mean he is running lutetium trials there. So.
Yeah, interesting that Dr. Soraya, my main oncologist, had said to me at my last meeting with him about 2 weeks ago. He said that that might be my next plan, and that I should talk to Tagawa about it, because Tagawa had previously mentioned he was going to be opening some spots in April. So we'll see.
Okay. All right. Thanks for the update, and good luck tomorrow. And send me a note, Carl. Send me and Len and Herb and Peter a note, and let us know how you did on the ARV 110. The article that I linked to in the reminder by Michael Glode does address the ARV 110, not directly, but it does address it. Herb pointed out to me that there's probably a better and more complex article written by Dr. Antanarakis and others that I haven't had a chance to read yet, and will be more difficult to digest. But Herb, do you want to just say something on that?
Well, I think the article you cited is really quite good. It really translates a lot of what Antanarakis had said in the review article in a little simplified form. But they did both talk about ARV 110 because it is a way of basically destroying the receptor, sort of by putting a tag on it that sends it to the garbage heap. Right. And so if that works, it's great.
Right. Okay. Anything else? Anybody else on ARV 110 or anything about ARV 110? Okay. John
Antonucci. Yeah, here's my question. My medical oncologist, Dr. Petrolak, took me off abiraterone last week because my legs had all swollen up, and he was worried about my cardiac status. So one question I had was that, that means a prednisone taper. And I can remember you guys talking about prednisone tapers in the past, but I don't really remember what you said, except that it had to be pretty long. Now, he told me gave me a 2-week taper. I wanted to see what people thought.
I'm gonna give that one straight to Dr. Carlos. Do you think 2 weeks is enough? How much were you taking? That's important.
Yeah. How much?
5.
5
Once a-
milligrams. That's plenty of time.
Okay.
If you're on more than 10, that's when you need to start slowing it down.
Okay.
Okay.
And probably, since I'm still on Lupron, I wouldn't be expecting to feel any different now that the abiraterone's gone. Does that sound right to anybody? Yeah. I see Herb's head nodding.
Yeah, I think that's correct, John. You're not making testosterone, so you won't feel anything major.
Yeah, my T level, I did get that after we talked a few months ago, and it's non-detectable.
Yeah, that's not going to change. I mean, the main thing that's changing is you're going to start to produce other steroids from other places.
Yeah.
Right? Your corticosteroids are going to come back, and that's why you'll taper the prednisone. And hopefully, they're on the same schedule.
And some testosterone would come back, right? That adrenal testosterone.
No, well, maybe.
Don't worry about that too much, huh?
Right.
I mean,
right.
the
Well,
abiraterone, as obnoxious as it is, it gave me a feeling of protection.
Yes, I don't disagree. So do you have other, John, do you have other cardiac problems?
I've been having some mysterious chest pain, and I'm getting a perfusion study with the cardiologist tomorrow. And so between that and the swelling, he just thought it's not worth putting any risk on my heart.
But I mean, if they show that after they do the cardiac studies, you may well be able to go back.
Yeah, he said that if it turns out that there's nothing wrong with my heart and the swelling in my legs go away, that he would probably go back. But he thought the first thing that came off of his head before we didn't have any discussion about this is that he'd go to enzalutamide.
Mm-hmm.
What is it that they think is causing what in the abiraterone is causing the swelling, or is it the steroid that it's down to?
I think he thought it was the abiraterone, but he didn't really. I don't know.
Does anybody know why abiraterone might cause swelling in the legs? It's not something I've heard of.
No, I don't. I mean, I think it may be in combination with other drugs. Are you taking any antihypertensives?
With my feet. My feet swelled from abiraterone, and my right foot is always still a little swollen from it. That is one of the symptoms listed as abiraterone symptoms, that is.
Okay.
And okay, well, that's I appreciate hearing that. And Herb, that's a very astute question, because I was on a calcium channel blocker. And
Yeah, well, that will cause peripheral edema right there.
Yeah, that was the first thing they got rid of.
Well, the one thing I will say, and your PSA, by the way, right now at the time that you're stopping, your PSA is what, John?
The last test was just a few days ago, and it's less than 0.008 is the way they read it.
So, I think you can watch what it does. You can see if it moves, and we like Petrolac. He's a good dog. So we have confidence. We have confidence in. You have confidence in abiraterone. We have confidence in Petrolac. So I think you can rely on him.
So a quick search basically says that abiraterone will increase your mineralocorticoid levels.
Okay.
And that may be responsible for the peripheral edema.
Yeah. Okay. Okay. So in that case, if we go back to something, maybe he will come up with a an androgen blocker, and I'll probably, if I get in that situation a couple months from now, I'll come back and ask for a recommendation. Which one?
I think what
Well,
Len is
which
taking
one?
looks.
It's a question of whether you'll get it. But
Yeah.
you know, we're all fans of darolutamide in bed.
Darolutamide.
If he'll give it to you, that's what we want to see you get.
Because you have to be castration resistant to get it, or why?
Non-metastatic castration resistance.
Uh-huh.
But the definition of a non-metastatic is tricky, but we don't have time to get into that right now. Okay?
Yeah. Okay. Thanks, guys.
John Haley.
This is John Haley. I don't have any need at this point, Rick.
Oh,
Thank
you don't? Okay. Okay, I put a tick by you and I didn't need to put a tick by you. How about Tom?
I think that was my fault. I think I answered for John Haley when I think I heard John A instead of John Haley.
Okay. Tom Swartzel, you're up.
Yeah, how you doing? I had a couple things to talk about. I came down with a case of melanoma on my back, and apparently they're going to probably take out a couple lymph nodes. Do they normally test for, since I have prostate cancer in my lungs and my, they normally test those nodes for possible prostate cancer?
I'm sorry, I got the part that they found some melanoma, but what was the question?
Well, they're going to take out some lymph nodes.
Right.
Do they normally test to see if any, well, in my case, whether any of the, there's any prostate cancer in those nodes? Is that like?
Where are they taking the nodes from?
Well, they have to inject a dye, I guess a radioactive dye or something, and take an X-ray.
Where are they taking the nodes from? Where?
Whatever is feeding the.
Well, they don't know. They won't know until they have to inject some dye where the cancer was.
Okay.
And see which lymph nodes are involved.
So in other words, they've seen this melanoma in the back. They've removed the melanoma. They want to check if there's any lymph nodes, but they're going to have to give you a scan in order to identify where the lymph nodes are. Is that right?
Yes.
Okay, Linda, come on in the picture, love, and talk to us. You don't have to coach him. You can tell us yourself. It's probably easier. Where on the back? Low down on the back?
About in the middle.
In the middle.
Near the spine.
Well, yeah.
Go ahead. I'm sorry. Go ahead.
No, what I was going to say is you can certainly ask them. You see, you're treated at the James, so why don't you ask Dr. Parat? Is Dr. Parat coordinating with the melanoma doc?
No.
So I think the first thing I would do is I'd make sure that Dr. Parak is aware of this and tell him, you just want to make sure that there's no trace. Number one. Number two, have you had any genetic testing?
Yes, for BRCA1 and 2.
No, he's actually had the complete group of scans. We talked with a genetic counselor, and everything that they tested for came back negative.
Okay.
The BRCA1 and BRCA2, but then there was like 13, 14, 15 other ones that they tested as well, and I can't tell you what they are, but they all came back negative as well.
Okay, well that's good. I was just going to say to you that if he hadn't, then we were going to send you over to our friend Lindsay Byrne because she's terrific. Is that who you saw?
Yes.
Yeah, she's lovely.
Yeah,
and we love
she
her.
was very helpful and explained very well.
Yeah.
Because we're newbies. We're definitely newbies at this.
Yeah.
Okay, you're in great hands with her. I think the answer to your question, it's way beyond my pay grade, is that, I mean, I do know there's a connection between melanoma and prostate cancer, but it doesn't sound like you have that genetic mutation. I think that you should make sure that Dr. Parak knows what you're doing, and if they are going to do any pathology, that he gets his 2 cents in as what he wants them to do from the pathology standpoint.
Okay.
Thank you.
Now,
hold on a minute.
I have another question.
I have a question for you.
Okay.
Have you made any progress in terms of the biopsies on the spots in your lung?
Well, that's what we want to ask you about.
We are going to see Dr. Preek at the end of the month and talk about that. The question is, do I go with an Axumin or PSMA scan? Which one's the better scan to go with?
Well, it depends. What's your current PSA?
0.07.
Yeah, it's essentially 0.028.
Sorry, 0.028?
Yes.
Okay. So neither of them is going to do you much good at this point because you don't have a high enough high enough level, PSA level. You've really got to get up at least to 0.65. I mean, some people are doing PSMAs at 0.2, but if you do it under 0.5, the results are fairly unreliable. And for an Axumin, you want to be at least at 0.85. So what that means is in order to get a result, you have to do like we talked about before, where you have to let your PSA rise, and then you can go in and do the scan. Right now at 0.028, you're not going to get a result from either.
How dangerous is it if he would, back off on his meds in order to let that go back up, the PSA go back up?
Good question, and I'm going to let some guys on this call answer that because they've been faced with the same problem and decided what to do. Who has decided to hold off on, who's waited so that they can get an Axumin or a PSMA? Anybody on the call?
Okay.
It's not.
Okay.
All right.
Well, Rick, I can tell you this. I had an Axumin scan when my PSA was at 0.8 and it didn't show anything. And then 6 months later, I had a PSMA PET scan, which is more sensitive, and that revealed that I had several bone mets. So yeah, that kind of is what Rick is getting at. If your PSA is too low, Axumin is not really going to pick up lesions that may be there. And I think Medicare only pays for one Axumin scan per year.
Mm-hmm.
Right.
Right.
Now, but the question I have is, who's waited? Who's gone off their meds so that they can? I mean, Len, in effect, you did because you were on a holiday and you decided to wait and you didn't go back on, right?
Yeah, that's right. Yeah, that's right. I didn't go back on until my PSA got to a high enough level for it to be detected.
Right. And Linda's question is, how dangerous was that?
Well, yeah, in retrospect, maybe I stayed on drug holiday for too long. But that was because I was waiting to get into a clinical trial at the NIH, and it, for reasons I don't want to go into right now, it just took forever to get into the trial. I'm going to blame Herb for that because he works there. But
Sure, go ahead.
but you
So
know, go ahead.
Did that make when you decided to go back on your medicine, was that because it had become more aggressive again? Had it progressed?
Yeah, it had progressed. But I mean, at least I knew where it was, so I knew what type of treatment was required. If I didn't do anything after taking the Axumin scan and it was negative, it would have progressed anyway, right? Because I obviously had something going on. The PSA was rising, but the Axumin scan didn't show anything.
I mean,
well, we still question what was in his lungs, whether or not it is actually prostate cancer or whether or not it was a infection that was resolving itself, that, you know, the scans that he had picked up on. So people are saying, well, it most likely is prostate cancer because it shrank, but nobody's definitively saying it's prostate cancer. So Tom could be on all of these high toxic medicines for years and not have advanced prostate cancer, but localized prostate cancer. But you know, so we're in a catch-22 spot right now and don't really know how to resolve it. So if anybody's got any ideas, we'd be eternally grateful.
Well, I mean, let's you let your PSA rise enough so that you could get it seen on a scan, right?
Who are you talking to?
Les.
Oh, Les.
Les? You're
muted.
muted.
I didn't quite follow the question here.
We're asking about people that have let their PSA rise and not gone back to drugs so that they could see something on the scan.
Yeah, but it wasn't done for that reason. It just that it shot up so fast that it was up to like 3.8 or whatever by the time we got to the scan.
Okay.
But it wasn't done for the reason that you mentioned.
Okay, so you weren't holding up to drive up your PSA so you could get it scanned.
No, no, that was not the intent. No.
Right. Anybody else held off their meds so that they can drive up their PSA so they can see it on their scan?
Rick, mine is similar to that with the intermittent treatment, which is common. A lot of guys will do what they call intermittent treatment. And you get your PSA low enough, which it sounds like yours is very low. And you can just stop your treatments and just do your PSA, watch your PSA. And as it rises up to a point where it's eligible for a PSMA scan, to get the PSMA scan. So it's not what I would think of as a risky proposition.
Thank you, Dennis. That's kind of what I'm trying to draw out of the group to hear from other people, because I think that's Linda's question. Pat Martin.
Yeah, my Dr. Schweitzer up at SCCA, he kept me off abiraterone and Leukerine for long enough he could calculate out by my PSA doubling time when it would hit 1. Well, he had me an appointment on that day, and so he could justify doing an Axumin scan. And so I didn't choose to do that. It drove me crazy, knowing that my PSA was doubling quickly, but he held off on it. So he found it in February. I got back on stuff, back on track. Now it's down.
So as soon as you had the scan done, then you went back on your medicine and had good results when you went back on it? Is
Yes,
that what
I
I'm
did.
understanding you saying?
Yes, I did. My PSA, he allowed to get up to 1.1 or 2. And then inside of 2 months, it's down to 0.17. And so it's down. I'm back on ADT, Abby and Eligard. I tolerate them well. So
I mean,
it was a measured calculation that he did to get me to a PSA of 1 point something, so that the Axumin scan would pick it up. So.
Okay.
So I think, Linda, this is what you're driving at, isn't it?
It truly is. It gives us some things that when we always obviously sit down before our appointments and write out a bunch of questions, we'll ask about that. And this way, at least we have a starting point. Whereas prior to talking with you guys tonight, we were kind of floundering a little. So this gives us some direction.
I mean, I think it's up to each of you to see how you can deal with it, but we see quite often that men will either hold off going back on their meds or their doctors will take them off the meds in order to try and get a result out of that scan. Linda, when you write up those questions, do you give the doctor a copy when you walk in?
Yeah.
Good.
We always have a set for us and a set for them. So yeah,
Good.
We're all on the same page.
Okay, we're all on the same page too. That's very important. I'm glad you're doing that. Okay, we got to keep going because we're late now. We're almost through, but hopefully that's sort of been helpful to you and it's answered your questions. I think Ravi is gone. David Muslin, are you with us or not? I see a David Muslin icon on my screen, but I also saw that you left, so I'm not sure. Are you with us? Okay, I'll get a hold of you later. I'll send you a note. And Jimmy G is gone, so I think we've covered everybody. I think David, Ravi, and Jimmy G all left. Jimmy G, by the way, was in the hospital in Hopkins over the weekend with a horrible fever of 104, and nobody could figure out what the heck it was. It wasn't COVID. Nobody knows what it was, and he sounds like he's back to his normal self. Probably wasn't even related to the AUS, but we have no idea what made him so sick. Anybody that I have missed who came in late that wants to pipe up before we close out?
Yeah, this is Eric.
Oh, hi, Eric.
Yeah.
Oh, Eric, I'm so sorry. Oh, my
Not,
gosh.
not a problem. I just wanted to just give a quick update. So I'm started my second week of radiation, and I've been taking Rolagolics for the last 15 days, and I'll be on that for another 3.5 months. So the question that I have is that, my doctor at one time said he wanted my bladder full, but now he's saying he wanted empty, and he wants, I guess, for lack of a better word, my rectum as clear as possible. So I've been taking Mirlax, but I'm not sure how good a job is that doing. So he said, to experiment, but does anyone have any solutions or any things that help them when they were going to get their radiation?
Yeah, when I did my radiation, to be honest, they gave me no instructions for my bladder and no instructions for my colon. And I had a really good doc, and I went to a very good place. Now, sometimes they tell you got to have a full bladder. In your case, what they're doing is a slightly different type of radiation. They're not radiating the prostate, they're radiating the pelvic girdle, I believe. I don't know how you can constantly have an empty bowel. Dr. Carlos, any thoughts on that one?
Yeah, I'm not a real fan of bowel cleaning, having had it done myself for a couple of scans. There's no real gentle way. If you need an empty bowel.
Somebody mute Gary Peters, please. Thank you.
I was trying to.
Sorry, go ahead, Gary.
Eric, I'm dealing with that same thing now that I've started. Miralax didn't work very good for me either. I'm trying Senna Plus. You can get it in any drugstore called Senna Plus.
Okay.
And the other thing, which is stronger as you move up, is a laxative called Senecot, Senekot, or milk of magnesia.
Okay.
God, Senecot. My mother used to take that. When I was a teenager, it came in a green and yellow package. In the UK, it was in a green and yellow tube. I can see it right now. I can see the colors of the tube.
It is still around.
What about a diet? Have you been on a low residue diet, or that's not part of it?
What is a low residue? What is that type of diet? I'm not sure what that is.
Well, it's basically foods that don't leave much of a residue. Easy to.
I've been
low fiber.
I've been doing that pretty much myself. Just staying towards a Mediterranean diet, and doing like.
Hold on, Eric. Hold on. That's not what you want to do now.
Oh, okay.
All the things that are really healthy and you're supposed to do for prostate cancer. Forget it. All the other things. All the crap that you are not supposed to eat. White bread.
Pasta.
French fries. Enjoy yourself, man. Whilst you're doing the radiation. And then when you're all done with it, you'll have to go back on this good diet that you're on.
Really? Okay.
Yes. Okay. Now, let me make a serious, and this is very serious. I mean, they do recommend a white food diet. White rice, white bread, potatoes, all of that stuff is fine when you're going through radiation. Ask your radonc to set up an appointment for you with a dietitian at Hopkins or Sibley. I forget, are you at Sibley or are you at Hopkins?
Hopkins.
Okay, so ask the dietitian, ask the doc or the radiation, send a message through when you go in tomorrow, send a message to the radiation tech or use the portal and tell them you want to see a diet, you want to consult with the dietitian as quickly as possible.
Okay.
And she'll give you the best diet for the period that you're on radiation. How many sessions are they going to do with you?
So it's going to be for 6 weeks. He said that it was going to be 28 sessions. So I go every day, Monday through Friday for 6 weeks.
Okay. So it's 28. So yeah, I definitely would suggest you get together with a dietitian as quickly as you possibly can.
Okay.
They will really help you. And then these other suggestions, the Senecot, the Senna, whatever it was that Gary suggested, Castor Oil. Carlos says Castor Oil in the chat window here. But but that's it. And it will work. But try and get yourself that consult with the dietitian as soon as you can.
Okay.
Okay.
Yep, I would do that. I'll send them a message to the portal.
Stick with the dietitian, because once you're off the radiation, they'll work with you to get you a healthy diet. The other thing is try and get a walk in every day after your radiation. Okay.
Yeah.
30-minute walk after your radiation, it'll stop you feeling quite as tired. Somebody asked me about that today that I wrote to. I forget who it was. Someone else is going through radiation.
Yeah, I've been doing pretty good with that. I usually go for like, at least a 30-minute walk, every day. I take it on my lunch break or when I get back, but I usually do that every day.
Okay. And again, my apologies for skipping over you. Sorry, I don't know how that happened. Next time you move up in the list for that. I'll make sure. Okay.
Not a problem.
All right, guys. I think that's about it. Next meeting will be on the 11th, next Tuesday. Please remember that meeting starts earlier. So don't come in at 8 o'clock Eastern, because you'll find that we are stopping and not starting. That's happened a few times recently. That meeting starts at 6 o'clock Eastern. Figure it out for your time zone. It'll either be Len or Peter, depending on Peter's travel schedule. And that's it. Fill out the survey.
And don't forget the survey. If you fill it out right now, you'll be finished in 9 or 10 minutes by the half hour.
Thank you, Joe. We have a number of things that we want you to do, but we'll wait until the survey's done on the other thing. Okay? All right. Thank you, guys, and good night.